A 7-year-old sitting in an exam chair rarely has the vocabulary to describe a systemic immunological collapse or a degrading cranial nerve pathway. A standard pediatric presentation often looks like Taylor, age 7. She struggles academically, she reads slowly, and a standard refraction yields a routine plus 1.25 hyperopic prescription. You prescribe the lenses, and the problem is solved. But relying on that baseline expectation is dangerous. Severe, life-altering pathologies routinely present with entirely white, quiet eyes. The symptoms are ambiguous or completely absent. In this assessment, we are isolating 3 specific pediatric presentations: the unresponsive pupil, the silent arthritis, and the swollen eye. Differentiating a benign condition from a life-threatening threat requires a complete rejection of subjective patient reporting. You must rely exclusively on objective anatomical and pharmacological metrics. This diagram illustrates the structural framework required for that differentiation, the diagnostic decision tree. Waiting for a child to complain of vision loss is a trap. The clinician must actively force the hidden pathology to reveal itself before irreversible damage occurs. The first presentation features a unilateral dilated pupil. The patient shows a massive accommodative lag on dynamic retinoscopy, yet accommodative facility remains normal. Observation reveals light near dissociation. The pupil fails to constrict under direct light stimulation, but it does constrict when the patient converges on a near-focus target. This logic tree maps the strict process of elimination to locate the neurological lesion. Starting with the dilated pupil that fails the light response, we strike Horner syndrome, an inability to dilate, whereas our patient fails to constrict. We eliminate cranial nerve 6 palsy because the patient exhibits normal extraocular motility. We also rule out cranial nerve 3 palsy by verifying the absence of ptosis and confirming the eye is not laterally or inferiorly displaced. This leaves one primary suspect: uveitis tonic pupil, indicating parasympathetic pathway damage at the ciliary ganglion. To prove this diagnosis, anatomical observation is insufficient. We must force a response using pilocarpine drops. Using standard 1% pilocarpine here is useless. A 1% concentration is highly potent and will constrict a perfectly healthy pupil, generating a false positive that tells you nothing about the ganglion damage. Instead, we leverage denervation supersensitivity. When the ciliary ganglion is damaged, starved postganglionic muscle fibers upregulate their receptors, becoming hyperreactive to trace amounts of acetylcholine. We exploit this biology by applying an ultra-dilute concentration of 0.125% pilocarpine to the affected eye. This weak solution will have zero effect on a normal pupil. It will only trigger constriction in the hypersensitive, denervated uveitis pupil. Executing this pharmacological test moves beyond simple observation, providing definitive proof of a neurological lesion. The second case focuses on Sebastian. He is doing exceptionally well academically, and his only reports are occasional eye redness and intermittent blur when looking at the whiteboard. His medical history reveals juvenile idiopathic arthritis in the right ankle, alongside a visual acuity deficit of 6/12 in his right eye. The chronological timeline of that arthritis dictates his ocular risk. An arthritis onset before age 4 correlates with the highest risk of serious ocular involvement. This diagram isolates 3 immunological risk factors: onset before age 4, an ANA-positive blood test, and the HLA-DRB1 gene. Their intersection triggers JIA-associated anterior uveitis. The paradox of this inflammation is the eye remains entirely white and pain-free. While the eyes may appear quiet, the 6/12 vision in the right eye is a critical signal of active pathology. This vision loss justifies an immediate, aggressive hunt for cellular debris in the anterior chamber. Detecting the threat requires a forced anatomical inspection. You must drive a small, focused spot beam from the slit lamp directly through the anterior chamber. You are hunting for the physical debris of the immune response: inflammatory cells, suspended protein flare, and signs of secondary macular edema. In pediatric autoimmune cases, the absence of pain provides no reassurance. The clinician must actively hunt down the disease's cellular footprint before it causes structural blindness. The final presentation represents an immediate acute crisis: a 6-year-old child presenting with a visibly swollen, highly inflamed, and uncomfortable eye. The differential diagnosis here is binary. You are looking at either a superficial preseptal cellulitis or a potentially lethal orbital cellulitis. This cross-section shows the precise anatomical boundary separating those two conditions, the orbital septum. To determine if the infection breached that barrier, we apply a strict triage flowchart, separating the presentation into mild and red flag pathways. Red flags indicating a deep tissue breach include proptosis, decreased visual acuity, and severe headache. The definitive clinical proof of orbital involvement is painful or restricted extraocular movements. If the eye cannot rotate normally, the infection has compromised deep muscles. If any of these red flags are present, the condition is managed as orbital sepsis. This requires an immediate hospital transfer for intravenous clindamycin or oral trimethoprim with sulfamethoxazole. If the presentation fits the mild preseptal pathway, the swelling will be minimal, the child can still open their eye, and they will show zero systemic fever or lethargy. Preseptal management requires prescribing oral cephalexin for 7 to 10 days, followed by a non-negotiable clinical review within 48 hours to ensure the infection isn't advancing. Accurately mapping that exact anatomical boundary is the single factor that determines whether you write a standard prescription or call an ambulance. A unilateral dilated pupil, a quiet eye with an underlying arthritis, a swollen eyelid. This unified diagram demonstrates the operational requirement linking all three cases. Surface symptoms are unreliable. The true physiological driver must be isolated manually. The anterior segment and pupillary pathways function as direct, accessible proxies for the central nervous system and the systemic immune system. Accessing that data requires specific tools: pharmacological testing, microscopic inspection, and rigid adherence to algorithmic flowcharts. Elite clinical practice never waits for the pediatric patient to explain what is wrong. It actively intercepts the disease through relentless, objective deduction.